So today I'm going to be talking about using Sorbact in burns, particularly in the burns that are superficial partial and indeterminate depth. So making the diagnosis is really where your dressing choice starts. And in the case of a superficial partial thickness burn, it's a burn commonly caused by hot water or liquids, classically pink, shiny, and moist looking, with very brisk blanching or capillary refill. The natural history of the superficial partial thickness wound is that it will heal within 21 days, usually by day 14. And this occurs by the process of epithelialization. And there you can see the wound has healed. There's no open wounds per se anymore. And it goes from being shiny to a more opaque appearance. And you see those little pigmented stipples. Those are the epithelial cells around the hair follicles or the sweat glands that generally heal first. The pigment comes back and then they coalesce. And this patient will regain pigment, which should be fairly close to normal. Those epithelial cells that move across the wound are disturbed by frequent dressing changes, and that can ultimately delay healing through the process of trauma. And then, of course, you've got the unnecessary pain. And this is one of the problems around daily Gelonette dressings, even every second day, or the classic use of flamazine, which is so historically associated with burn wounds. And that's one of the problems. It needs to be changed every day, and this disturbs the healing process. And in fact, sort of literature looking at wound healing and various options have shown flamazine to delay healing, particularly in superficial partial thickness burns. And there are a number of more modern options available nowadays. Also to remember that donor sites are superficial partial thickness burns. We identify them by punctate bleeding in theater, and they behave like superficial partial burns and should heal within 14 to 21 days. And again, premature removal of that primary dressing layer causes bleeding and disturbs that healing process. So the goals of care for partial burns and donor sites are to prevent infection, prevent trauma, and promote healing. And Sorbact is one of the options available that we like in Pietermaritzburg. How does it work? Well, it's a dialkyl carbamol chloride coated piece of fabric. It's strongly hydrophobic, which means it's water repellent, and it's those properties that bind to the hydrophobic cell wall of pathogenic bacteria and fungi by the physical principle of hydrophobicity. It will adhere to the wound bed over sort of the first 24 hours. It's binding that bacteria, but it also promotes epithelial cells to migrate across to heal that partial thickness wound or donor site, but it allows exudate through it to reach the secondary dressing and be absorbed, and that can be changed. There's no known or reported resistance. There's no cytotoxicity, and it doesn't promote the release of a bacterial endotoxin by a chemical nature. So it's basically, it's a physical inactivation of the bacteria bound to that water repellent Sorbact layer. You get it on its own. You can also get it in combination with other things like hydrogels or foams or more absorbent secondary dressings. How we use it: you should clean the wound of all loose slough and debris, as well as cleaning the adjacent normal skin. And we generally are using chlorhexidine gluconate. And if you have it available, Prontazan solution could be used as well. And really the emphasis here is on cleaning both the wound and the adjacent normal skin. You will make your assessment of the burn depth, which in this case would be that of partial thickness. You place the Sorbact onto the wound. You must have some overlap onto normal skin, not because it shrinks, but really because it can shift a little bit. And if it shifts, and then if you've got the gauze, then with no intermediate layer, the gauze sticks to that partial burn and is quite painful to remove and itself causes bleeding. You would then choose your secondary dressing, which can be a number of different options based on the exudate of your wound. And the last part is fixing the dressing. I'm a big fan of Hyperfix. Elastomesh is that sort of net, very useful for the face. Or you can fix the dressing with a simple bandage. Then you need to review that primary layer, which is the Sorbact, in around about 5 days. You've got to be a bit practical. And you want to look at the outer dressing, and they should be dry. And if the donor sites, they may be a little bit bloody, and that's okay. If the gauze peels off easily, you inspect the Sorbact. But if the gauze, and then you must not remove that Sorbact layer. You should leave it on there. Sometimes you will not be able to remove the gauze, but if it's dry as well, you can leave the gauze in place. And here are some other examples of how that nice dry Sorbact can look. This is desirable. This is how we want it to look. Note in the middle picture, the gauze, the Sorbact hasn't been placed very well, and you can see the wound peeping out in between. You shouldn't have that. It really should cover the entire wound. And these are all how we want it to look. So the Sorbact initially becomes adherent to the wound bed. Removing it at this stage is traumatic and pulls off the new epithelium, causing bleeding. So don't take it off. And what we want to do then is replace the secondary dressing, the gauze or the foam, and your bandage and fixation, and you will review it in a week. At around day 10 to 15, that Sorbact will still appear dry and maybe peeling off in places. And now you need to see whether you can gently peel it off. It is a learning curve, and you will feel it give a little bit versus being extremely adherent. Then you need to leave it in place for another week and peel it off at the next, typically the clinic visit. And this is just a video demonstrating how it comes off with really not very much resistance. And there you see a completely healed and epithelialized superficial partial burn underneath that Sorbact. And that dry flaky layer is normal, and that can be washed gently with soap and water and then aqueous cream applied on the scar. So that wound is completely healed and doesn't need any further dressings. There, just a little bit of a close-up. And here are some of other examples of how in places where we've used Sorbact. It's fairly versatile. It's great on the face. We usually use elastomesh over that, and you see already the pigment is starting to return for this young lady. Here's another burn that was actually maybe a little bit more indeterminate or intermediate depth, but completely epithelialized and healed. Another one that looks maybe a little bit more patchy, but in fact has healed. And this is another case. Yeah, this was long ago, back in the days where we used to sort of expose the wounds and wait to see them. And that's just some cling film to keep the patient a little bit more comfortable. And this picture on the right-hand side is post-use of Sorbact, 2 weeks following the burn, and you see the pigment already coming back. So in summary, the superficial partial wounds appear pink and shiny with brisk capillary refill. We need to prevent infection and trauma, and we know the wound will re-epithelialize in 21 days. Sorbact is used as a once-off dressing after cleaning and removal of the blisters. It adheres to the wound bed and should not be ripped off. If it appears dry, it will peel off on its own about 10 to 14 days. And if it's still too fixed, you can do that at day 21. But if it looks wet, then the Sorbact must be removed and replaced, as the burn may actually be deeper. And this is what we're going to look at now. Making the diagnosis of an indeterminate burn is a little bit more difficult. And by indeterminate, we mean that we're not convinced that it's superficial partial and will heal, but we're also not convinced that it needs to go for surgery and excision and grafting. There can be a number of causes: flame, hot water with a longer exposure time, or in places of thinner skin, or patients with thinner skin like little old ladies or quite small babies. Hot oil is another one. The wound looks pale and mottled, and the capillary refill is quite sluggish. These burns are named as such because the healing potential is uncertain, and the burn wounds are often quite mixed and heterogeneous in places. Some patches will heal by 21 days. Those are the superficial partial burns, and some will not heal by 21 days. And those are obviously the deep dermal ones. And here's a picture demonstrating the patches that are unhealed at 21 days versus the rest that is completely epithelialized and healed. That's the superficial partial component. Ideally, these deep dermal parts need a skin graft. If they don't get skin grafted and they are left to heal on their own, it results in hypertrophic scarring. Here's another picture of an indeterminate, quite mixed burn. This is much earlier in the presentation. And here you can see that central patch. There's some thin slough, still indeterminate. It may or may not heal by 21 days versus that more outer layer that really looks to be superficial partial. And I'm pretty sure that will heal by 21 days. The goals of care are also to prevent infection, limit trauma, and promote healing, but with the added goal of determining the superficial versus the deep dermal patches, because those deep dermal patches need grafting. The follow-up of that type of wound and dressing with Sorbact, it also needs to be reviewed in about 3 days. Again, choose what is practical. We remove the secondary dressings and bandages. And now we're looking for wet versus dry patches with the goal to cut away or completely remove if it's wet, but to leave the dry patches alone. Replacement of the secondary dressing, and you will repeat that every 3 to 4 days until day 21, so that you can then determine which are the deep dermal patches. So this is another way of looking at that. So the first question you need to ask yourself when you're using Sorbact in this type of way is, are you sure the wound depth is superficial partial? If the answer is yes, then generally it's a single dressing. You change the outers only, and you don't remove it until it's re-epithelialized, as we demonstrated earlier. The answer is no, it's probably deep. Then every dressing, you should remove that Sorbact dressing. A deep eschar can still dry out, and that can lead you into a false idea that things are going well. But if you know you are using Sorbact on a deep wound, then you know you need to remove it. You won't be causing any damage of the underlying healthy cells because you've got that generally thicker eschar. So you're not going to be causing damage. And that's a different type of wound completely. Versus the middle one where you're saying, I'm not sure, I think it's indeterminate. Then when you re-examine the dressing, you're looking for wet versus dry patches. You leave the dry patches alone and you cut open those wet patches. So here's an example, clearly very different to the pictures we saw earlier. These are indeterminate, heading towards deep dermal burns. The Sorbact is wet, it needs to come off. And here's another demonstration. The face is really quite resilient. There's a good vascular supply, and we generally tend to manage it quite conservatively. And here was where we used Sorbact. And at 21 days, it's very clear that the forehead has healed versus the rest of the face is unhealed and is going to require skin grafting. Another example, so this one, very small patches were in fact superficial partial, and the majority is a deep partial wound, and that needs grafting. So in summary for this part, the indeterminate burns are mottled or red with sluggish capillary refill on presentation. Prevention of infection is important. We manage them expectantly. And really the key decision is at 21 days, where the deep partial component has declared itself for needing grafting. And if Sorbact is used, leave that adherent Sorbact to the wound bed. But if it looks wet, then the Sorbact must be removed and replaced regularly until that wound is grafted.